Welcome back to our Explainer series. Today we're doing something absolutely crucial. We're bulletproofing your documentation by decoding the single most scrutinized category in any outpatient audit. We are talking about high-risk medical decision-making, specifically looking at Chart C. For our certified medical coders, auditors, and CDI specialists tuning in, this is the deep end of the pool. When an encounter hits high risk, the stakes are enormous. We're talking about the patient's health, of course, but also serious compliance and reimbursement implications. If the clinical documentation isn't rock solid, you're literally looking at instant audit failures. So today we're going to break down exactly what warrants a high-risk level and how to make sure your charts perfectly reflect that complexity.
Here's our roadmap for today. We'll define the high-risk threshold, walk through drug toxicity monitoring, surgical risk and escalation, DNRs and controlled substances, look at a few common audit traps, and wrap it all up with a handy summary matrix.
Let's start with Section 1, the high-risk threshold, defining the ultimate clinical stakes.
So, what actually pushes an encounter into this highest level of scrutiny? We can't just guess what high risk means. We have to lean on the specific clinical threshold defined by E&M guidelines. The defining factor here is the severity of the potential outcome. We're talking about situations where, if the condition is mismanaged, there's a high probability of severe morbidity, permanent functional impairment, or even mortality. And morbidity here implies a state of illness or impairment that's expected to be long-term, where quality of life is severely impacted or actual organ damage occurs. If the management options a provider is weighing carry that kind of weight, you are immediately looking at high risk.
And auditing isn't just about tallying up diagnoses on a piece of paper. It is entirely about evaluating the provider's active, in-the-moment clinical judgment. Risk fundamentally comes down to the problems being treated and the massive decisions the provider makes during that specific visit. It includes the active choice to perform a treatment, to hospitalize a patient, or, and this is incredibly important to remember, the choice to delay or withhold further testing or treatments simply because of the patient's fragile state.
Moving right along to Section 2, drug toxicity monitoring, high-stakes pharmacology.
This is one of the most frequently coded and, honestly, most frequently audited high-risk categories. We are strictly talking about medications with very narrow therapeutic windows that demand intensive, frequent monitoring for severe toxicity. We aren't talking about checking a blood pressure after prescribing a mild diuretic. No, we're talking about drugs like warfarin, where frequent INR lab testing is absolutely critical to prevent fatal bleeding. A surprising fact for you. Missing the documentation for this specific monitoring is actually one of the top 3 reasons outpatient audits fail. Or it takes systemic immunosuppressants and chemotherapy regimens that require close clinical follow-up for life-threatening side effects. The provider has to be actively assessing the patient for these severe toxicities for it to count in this category.
Okay, Section 3, surgical risk and escalation, evaluating the patient and the procedure.
Here is where a really sharp coder or CDI specialist proves their worth. You have to look at the whole patient, not just the procedure. Let's compare 2 scenarios. If a generally healthy patient comes in for an elective joint replacement, that falls under moderate risk. But what if you have a patient coming in for an elective hernia surgery, but they have a severe cardiac history, poorly controlled diabetes, or bleeding disorders? Documenting those severe comorbidities instantly escalates the surgical planning to high risk. The patient's underlying health makes the anesthesia and the surgery itself a high-stakes clinical event.
Similarly, whenever a provider makes an immediate, high-stakes decision to escalate care that undeniably meets the high-risk threshold, if a patient is in the clinic and the doctor realizes they have a ruptured appendix requiring emergency major surgery, or they make the call for an acute direct admission straight to the hospital or the ICU, that is high risk. The provider is actively managing a threat to life or bodily function right there in the office.
Let's look at Section 4, DNR and controlled substances, navigating complex care decisions.
These next 2 scenarios involve incredibly sensitive and carefully monitored patient interactions. First up is the decision to transition a patient to palliative care, or deciding not to resuscitate instead of pursuing aggressive life-saving measures. This is a highly complex, active clinical decision. Having an end-of-life care planning conversation, discussing poor prognoses, and making the medical decision to withdraw aggressive interventions carries the highest level of clinical weight and emotional complexity. This active decision-making process firmly lands in the high-risk category of Chart C.
Then we have parenteral controlled substances. Now, notice that specific word, parenteral. We are talking about intravenous, intramuscular, or subcutaneous administration here, not your standard oral prescriptions. Because of the immediate overdose and dependency risks, administering injected narcotics or controlled sedatives requires acute clinical monitoring. When a provider gives a parental controlled substance, they must strictly monitor the patient for respiratory depression and acute toxicity, which automatically places the management of that encounter into the high-risk category.
Moving to Section 5, Audit Traps and Documentation. Bulletproofing the progress note.
Okay, let's get into the practical application. How do we actually avoid the most common compliance failures? Because, as we all know, if it isn't documented properly, in the eyes of an auditor, it simply didn't happen. Here's where the rubber meets the road. Auditors will penalize a routine refill masquerading as high risk. If a provider just writes refilled warfarin, patient stable, an auditor is likely going to downgrade that to moderate or even low risk because it just looks like standard prescription management. The documentation absolutely must explicitly state the active intensive toxicity monitoring that's taking place. Something like reviewed INR labs adjusted warfarin dosage due to narrow therapeutic window and bleeding risk. That explicitly shows the high-risk cognitive work the provider actually performed.
Finally, Section 6, Chart C Summary Matrix, the risk ladder visualized.
Let's bring all these concepts together into a clean, definitive structure. When you're reviewing a chart, you need to be able to instantly visualize where the encounter lands on the spectrum of risk. So think of this as your ultimate mental matrix for auditing. Straightforward is just minimal risk, maybe some rest or superficial treatments. Low is your over-the-counter medications or minor surgery with zero risk factors. Moderate steps up to standard prescription drug management or elective major surgery on a healthy patient. And then high risk sits right at the very top. Intensive toxicity monitoring, emergency surgery, direct hospital escalation, and DNR decisions. This right here is your ultimate cheat sheet for Chart C.
So, we've mastered charts A, B, and C independently. And remember, high-risk coding is never about padding the bill. It's about accurately reflecting the immense clinical responsibility the provider took on that day. But in the real world, well, these three charts almost never line up perfectly. So what exactly do you do when the complexity of problems is moderate, the data reviewed is low, but the risk of complications is high? That's exactly what we're going to tackle in Part 11 when we explore the 2 out of 3 rule and MDM tiebreaker logic. It's really the most important puzzle piece of them all. Until then, decode healthcare with Harshal.